Welcome back to the Maternity and Midwifery Forum. Maternity services haven't stopped over the last 16 months, and neither have we. We've continued to bring maternity and midwifery professionals and students the latest policy updates, best clinical and technical innovations, and research via our live-streamed festivals throughout the pandemic. We've introduced the Maternity and Midwifery Hour to enable healthcare professionals to come together as a community each week to share their experiences. We've even added a new festival to our annual series. The Student Midwife Experience Festival will take place on the 10th of November in Manchester and will be a great opportunity for student midwives and academics to examine how the current curriculum will react to changes in maternity services. We'll also be talking about what students want and how universities and educators can adapt their courses, mixing practical and online learning. We've also redesigned the Maternity and Midwifery Forum website to create a space where you can catch up with all the latest articles, watch videos, find out about forthcoming events, and advertise your own. Not satisfied with that, we will shortly be launching our new Maternity and Midwifery Services and Products Directory, a one-stop shop for all healthcare professionals who want to find out about the latest products, services, career opportunities, campaigns, courses, and resources. Take part in our exhibition competition today and get an early glimpse of the directory before it is launched to maternity and midwifery professionals and students later in July.
And welcome to everybody who's come this evening. I think we've got an interesting evening. I hope you're going to enjoy it.
I remember another patient who we both looked after who, was in a relationship with a chap, getting serious, thinking about starting a family. And I remember her bringing him to clinic, him getting tested, them coming back to get the results. He was trait. This was one of our patients who had sickle cell disease. And she dumped him in the room.
Yes, she did.
She dumped him in the room in front of
us.
I
remember. And I said, Mummy, I'd never let you get a vaccine that is not safe. So I'll be the first one there, and then once I've had it, you can have it. And I remember this text message coming back to me while I was at work, where you'll be the first to die. For every touch point, be talking to women about the importance about having the vaccine. And if you don't have information, say that to somebody. I don't have the information. Can I pass it on to the person that can?
Some women are saying that they're actually having a really positive breastfeeding experience because their situation of having to stay at home and not having lots of visitors around and not feeling they have to rush about everywhere means they've actually got the excuse almost to sit on the sofa and just breastfeed their baby.
So Black and brown women and birthing people are not treated with equity, leading to unacceptable levels of morbidity and mortality. They then become marginalised communities that become mistrusting of maternity services, and they might be reluctant to engage because their initial experience has been negative. We then label them as difficult and unwilling to engage, and the cycle of substandard care continues.
It's really difficult to describe really what makes continuity happen, but there is some real magic in the depth of relationship that you have with a woman and her family, and it's really beyond articulation. We know it works. It definitely works for our women and our families, and if you always put them in the very centre of what you do and how you work, that is when the magic happens.
And good evening to everybody to this week's Maternity and Midwifery Hour. Welcome wherever you are in the world. It's great to see everybody. Well, I can see my lovely speakers, and I'm seeing you all out there as well. Welcome to this 5th episode of the 5th series of the Maternity and Midwifery Hour. My name's Sue Mcdonald, and I'm the curator for the Midwifery and Maternity Festivals and this hour. And it's my pleasure to be chairing the session tonight. It's going to be fantastic. As many of you will know, these sessions were designed just on the onset of the pandemic last year as a way of linking up midwives, student midwives, people who want to become midwives, to give them some continuing professional development, and also a way of linking together and to get them information, nice and new contemporary stuff to keep them up to date with things. For those of you who are joining us for the first time, welcome first of all, but just to know that everything is recorded. So if you miss anything, or you want to share it with colleagues, or you want to use it for an assignment or whatever, these are all accessible on Netflix. So it's a fantastic resource if you're doing an assignment or you're doing a revalidation or whatever you might be doing. So great thanks to Netflix for getting that all indexed and everything. And tonight it's my delight, actually, to be joined by three wonderful speakers. I've got Nat Corden, I've got Dr. Tracy Cooper, and Professor Tracy Mcdonald. I hope I've pronounced that correctly, Trixie, or I'll be in trouble. And we're going to be talking continuity of care. And I've got a slight bit of deja vu because I seem to recall that we were talking about we talk about continuity of care a lot because it's the one key intervention that has a major effect on women, on babies and families, and on midwives. But I know we were talking about this last year, and I'm really so pleased we're talking about it again because it's really important in spite of the pandemic, in spite of everything else that's going on. But before we get on to that, I'm going to put each of my speakers on the spot, as we always do, to ask them to just present me with a moment of the week to share. And I'll start with Nat.
Okie dokie. So my moment of the week is a little bit of self-care today, spending time with my mum, and we had some lovely tapas together and had a lovely chat, and then I went to Primark and brought some lovely pajamas. Fluffy, beautiful, warm winter pajamas that actually I can't wait to put on, but I'm being professional and staying in this outfit for now. But I'm very tempted. They are close by.
Beautiful. Okay. And other makes are available.
Oh, of course. Sorry.
But wonderful. Isn't that a super example of how we need to all to look after ourselves? And Nat has illustrated that beautifully. So thank you so much, Nat. So I'll put Tracy on the spot now to share a little moment. You have to only choose one little moment.
Oh, that's the difficulty, isn't it, really? So what's been so nice for me probably is being able to go out and about and actually go on site to places. So I've been really lucky, and I can't mention one place without another. That's a problem. So I went to York last week and Hull this week to see how they're getting on with their continuity of carer, and just to be able to meet the teams face to face was really lovely, and for them to share what they've been doing with us was great. But also as well, I met some new students at the University of Sheffield who were doing a master's course to become a midwife, and they've already got degrees. So they're coming through based on a leadership and continuity of care course basis as well. So that was really lovely to meet those as well. So yeah, just being out and meeting people again, it's just been a pleasure.
But this is what's wonderful about Tracy. She's managed to squeeze 3 moments.
Sorry.
So well done. And how lovely to meet new students. And we know with the new, I'd have to whip this out, the new proficiencies, essential reading for midwives, and continuity is a really important part of that. So thank you for bringing that up. I'll pin that down on Trixie now for a moment.
Thanks, Sue, and hi everybody. Yeah, like Tracy, there's lots of moments, and I'm just constantly blown away by the resilience and by the positivity of the midwives I meet, as I'm also going with Tracy and others around to visit people. And today I had a particularly enjoyable experience because I was talking to a finance director and talking about the maths that sits underneath staffing and demonstrating how possible continuity of care is once you've understood the maths that sits underneath it. So that really cheered me up, but you might not all agree with me that that's such a good thing.
I think anyone that can talk to a finance director and get them, you know, on the same level with money, I think that's brilliant. Fantastic, Trixie. Well done. And thank you for sharing your moments of the week. Now I'm going to go just to highlight and just to say to everyone about, we still have COVID, that we're still using restrictions. We're still using our masks and our sanitizer. So we just want to say a big hello and take care to everyone who's involved in health services at the moment. Anyone who's suffering from COVID or long COVID, we hope you get well really soon, because it's grisly to have this bug. I know we're coming to a new normal. I would say personally, just keep being careful. It's worth it. A mask is no big deal. It really isn't, nor is the hand sanitizer. And you might stop yourself getting the grisly cold as well. So that has to be good. And we know everyone's really stressed and everyone's having to work really hard. So we just send another big thank you and a big virtual hug. And I'd say, from the words of Natalie, you need to look after yourself and find some really good self-care things to keep yourself resilient and well. So a big thank you to everybody. Now, there's still, for my news, I'm not going to say anything very much about petrol, because I think things are getting slightly better, but I know it's still stressing some people. And we know that work's underway for frontline staff getting their COVID vaccine, booster, which is fantastic. Don't forget your flu vaccine if you're eligible for that as well. Don't want that either. I wanted to also share a great bit of news that Professor Marlene Sinclair at University of Ulster has been being awarded an honorary RCM fellowship for her contribution to midwifery research. So that's absolutely fantastic. Congratulations, Marlene. It's so well deserved. That's fantastic. Other things that are going on, there's a Wellbeing of Women have all launched their menopause workplace pledge. I knew I'd trip over up there. And this is for employers to support women going through the menopause in the workplace. And that includes the NHS, includes lots of different organisations. So have a look at their pledge and see where you could use it in your own workplace. Be fantastic. I want to remind people that next week, from the 9th to the 15th, is October, is Baby Loss Awareness Week. So there's a lot of activities and a lot of awareness being raised on that issue. Other great news this week is the new drug being available for people with sickle cell. And it's the first, I think it's the first for a long time. I think it's 20 years, someone said. And it's going to make a real difference for 5,000 people over the next 3 years. And that's really fantastic. So really pleased about that. And also just to highlight that it's Black History Month this month. And one of the things I thought was really fantastic was a fabulous statue, which you could get on your resources sheet, which I put somewhere, which is available online. I've got a photo of it, this lovely statue of Henrietta Lacks, who was a Black woman whose cells led to huge medical advances. And this statue was made by a Black woman in the UK, Helen Wilson Rowe. And it's I think it's a fantastic statue. It really looks like a real person. And I'm sure, I mean, Henrietta obviously was a real person, and it's really lovely to see. And this week, I'm not going to say I'm reading a book. This week, I've mainly been watching the RCM conference, really good, all virtual, and really some fantastic speakers. And I know RCM members will be watching that as well and catching up. So have a look on the resources page, which is available. There's some references from Trixie and Tracy, and there's also a few from updated references for you to keep yourselves up to date. Right, that's a whistle stop tour now of the news. We're now going to move into the meat and drink of this session, and we're focusing on continuity of care. And this is in the context, it has been part of the maternity transformation programme, but obviously it's been impacted by COVID-19 over the last year. And in some places it might feel as though it's become a bit slow. Maybe the programmes haven't been rolled out as fast. But of course, it is known that continuity has a major impact on mothers and babies and midwives also. So I'm really delighted to introduce again Natalie Corden, who will be known to many of you. If you're a Twitterer or tweeter and a blog enjoyer, you will know Nat from that. She's a continuity of care midwife here in the South, and she's going to share her experience of being the joys and loves of being a continuity of care midwife. So thank you so much for coming, Nat. The screen is now yours.
Okay, so I sort of was asked to sort of come on here and have a chat. I don't have any fancy slides, I'm sorry, and I don't have any anything else to put up on the screen apart from my face. But I wanted to talk about the love I have for continuity, obviously, and what it means to me, and going forward, what it means to me. So the basics I wanted to talk about, because I think that's what a lot of people are interested in, like what are my basics, what is happening to me on a day-to-day basis. So I'm part of a team of 6. We started out as a continuity team last January, just before COVID hit. So we had a lovely clinical space in a children's centre, which unfortunately we lost within the first 3 months because it was shut due to COVID. So we made big adaptations almost straight away as a team. We were rotated to working days, and we had long days on call and night on calls. They are 8 in the morning till 8 at night, and vice versa. But with that, we have had to adjust those as well, because we found that having the strict days that were rotated didn't work for the women and didn't work for us. So we changed that and we became self-rostered. So in terms of my working week, I can have one long day where I'm on call for labour, and I go wherever the woman is, or I can have one night on call a week whereby I'm at home, and obviously I go out to wherever the woman is to care for her in labour. The rest of my days are what I want to do and what I need to do. So some weeks are very, very busy. I book 3 women a month, and I try to space those so that they're not all having babies in the same week. But as we all know, the magical due date doesn't really exist, and babies come whenever they want. So some weeks I can have a very high commitment to postnatal care, because I have 3 women that have their babies. So I'm going out to see them a lot. So some days are very full and some weeks are very full, and some less so. I wanted to sort of run through sort of maybe a bit of a day in the life. I read it out to my teenage son earlier on today, and he said, "That sounds really boring." And I was like, okay. It's like, thanks for the feedback. Beautiful. But then I just read it to my eldest son, and he was like, well, yeah, that's all right. That's what you do, isn't it? I thought, yeah, okay, we'll go with it then. So I'm just going to read out sort of an average day in the life of me and what I do. So it's a working day. I'm not on call for labour care, but I check my work phone for any overnight updates or day updates. I answer 3 text messages from my caseload. One is inquiring whether her partner can attend a scan, another checking our appointment time is this morning, and the last asking whether I could give her information on hiring a birth pool. I wish my team a good day via work phone WhatsApp and pack my bag for the day. I have a mix of postnatal and antenatal appointments, so it's a good idea to check over equipment, stock and paperwork before I get out on the road. I arrive at the hospital to see a woman booking for her first pregnancy. I check my phone, and again there are messages from the caseload inquiring about blood results and one asking about newborn behaviours. The booking goes well as I explain the team care and the expectations of continuity of care. I complete paperwork and take booking bloods. I then see antenatal women till 12, and it's great to see they're all going well in their pregnancies. Before I leave, I check my inbox and reply to an email about a consultant appointment I had requested for a woman. I add appointments to my work calendar for the next few days. I head out on the road after a sandwich and a fizzy drink to see my postnatal women. It's wonderful to support the women in their feeding choices and seeing their first few days as new mothers when you've cared for them throughout their pregnancy. It is then time to get back to the hospital. I get my NNST samples checked by a colleague, check the intro for any referrals. I remember that I need more blood forms to do a 28-week check, and so I print them off. The admin team in the office take a call, and they ask me to speak to a woman and reassure her about her baby's umbilical cord, and I give reassurance plus signposting. My teammate is in the office as she's working the long day and has been called in. She describes the lovely birth she has attended. I check she doesn't need any help, as I can do the NIPE examination. She's already organised it, so I bid her farewell. I arrive home and I check my work phone again, a few more texts to send and signpost into triage for a woman that has concerns that her waters are broken. I log on my laptop and cash up the morning's appointments while adding future appointments. I remember that my e-learning for resus needs redoing, so I do the reading and assessment. It's the end of the day and I check in on the day's events in the team via WhatsApp and make the night on call midwife aware that a caseload woman may be attending triage for a query SHROM. I then turn off the phone as it's the end of my day. So it probably does sound a bit boring, but I thought it, just lay out the basics. I wanted to say about continuity that I really feel it's a lived and a loved experience. In that, I mean, the lived experience can be really challenging. It is learning to adapt. It's a totally different model of care. If you've been a rotational midwife, then this is a big change for you. To take on a caseload, to be an autonomous practitioner, making care plans and following through those plans, it can be really tough in the beginning. And then, you learn, you adapt, you learn how to time manage better. In some cases you don't, because we're all human. The lived experience of sort of having a team and building a team is really great. I've loved it. Building the connections between the team and having really good team leader has made the experience for me. The loved experience I talk about, and I grin from ear to ear, and I tell everybody that ask me about continuity, is the love, and I do mean sort of hearts, but the love that the women give me and talk the way they talk to me, and we see it in sort of evaluations and the feedback forms and things like that. But the way that the relational continuity, the actual connections with women, is what I became a midwife for. And I feel that's what I'm having in my job role now. So that's what I call sort of continuity, lived and loved. Going forward, there's still a lot to do. There's still stuff that I want to do as a continuity midwife. I want to improve in more outcomes. I want to do better, and that's what I strive to do. In terms of the team, we've changed. We've adapted, as I said. We're now a mixed risk caseload, whereas at the beginning we were taking on only low risk women. We are postcode specific now, which was quite a big change, because we were sort of dotted around an area rather than being in one area and seeing what impact we could have on one area. And sort of my own sort of responsibility wise, I feel like I really want to look into how we are sort of reducing the use of epidural, and how we are sort of like helping our women to stay at home when they're in their latent phase and coming into hospital when they're in established labour, and in getting more women to have home birth as well. I've had some beautiful home births with the team, and women having their first baby at home is absolutely, is a dream. It's an absolute dream to be with them and support them when they do that. So that's really me. I don't really have much more to say other than I love it, and we encourage people to do it. Step out of their comfort zone, think about the bigger picture. What you came to be a midwife, why did you want to do it? And if that drives there, then go for it. You won't be disappointed in sort of the way that it works. So that's me. Thank you for listening, and obviously I'm open to questions. Anyone wants to ask me anything at the end of the session.
Fabulous. Thank you so much, Nat, for setting us up for this now. That's great. And I'll say to the audience, if you've got questions, we've got a few coming through. And we've got a time at the end of the session, as we always do, for some questions. So if you have a question for Nat, and it could be something about how she organises her off duty, but not too many arithmetics, I suspect. I don't know. So thank you very much, Nat. We'll move on now. We've got a little bit of a double act now. So I'm very pleased to introduce our double act, which is Dr. Tracy Cooper Mbe. She's the Regional Chief Midwife for the North East and Yorkshire, and she was awarded her MB in 2018 for her contribution to midwifery. And she's had an outstanding contribution award for midwifery and maternity services, and she became a fellow of the RCM in 2017. She's worked in all areas of midwifery and especially head of midwifery, consultant midwife, whole list of things that Tracy's got up to in her past. And then we have Professor Tracy Cooper, who's highly experienced also. She's been a consultant midwife, head of midwifery, and she's currently the National Midwifery Lead for Continuity Care at NHS England and Improvement Team. And she's also Professor of Midwifery and Maternal Health. I hope I've got that correct now, Trixie and Tracy. And welcome, and the screen is now yours.
Thank you, Sue, for that lovely introduction. I'm going to do the first few slides and then Trixie's going to do some, if that's okay. So I just wanted us to go back really to talk about the evidence and reminding ourselves what it is about continuity of carer that makes a difference to outcomes for women and their families. So there's been a few Cochrane reviews over the time, and with so much evidence, it's hard not to say that it is actually making a difference. So if we start with the midwifery-led care Cochrane review, which was by Sandel in 2013, it showed there was a reduction in epidural, episiotomy in instrumental birth, and there's also a trend towards a cost-saving effect for midwife-led continuity of care compared to other models of care. And then in 2015, midwife-led continuity models versus other models of care for childbearing women showed that women who received midwife-led continuity models of care were less likely to experience intervention, more likely to be satisfied with their care. And they found that it was at least comparable with adverse outcomes for women or their infants when women who received other models of care. Then another Cochrane review, midwife-led continuity models versus other models of care by Sandel in 2016, again showed that women who received midwife continuity models were less likely to experience intervention, more likely to be satisfied with their care, at least comparable adverse outcomes for women or their infants with other models, fewer preterm births, fewer fetal deaths less than 24 weeks, and fewer overall fetal loss and neonatal death. And the continuity of care Cochrane review by Hodnett in 2020 said that women who had continuity of care by a team of midwives were more likely to discuss antenatal and postnatal concerns, attend prenatal classes, give birth without painkillers, and feel well prepared and supported during labour, and also feel prepared for childcare. And resuscitation was less frequently required for their babies as well. And then we have interventions during childbirth to prevent preterm birth, which was an overview of Cochrane systematic reviews, which was by Medley et al. In 2018, and showed that there was clear evidence of reducing perinatal risk of preterm birth from midwife-led models of care for all pregnant women, so women of all risk status. So what are the most effective interventions during pregnancy for preventing stillbirth? This was a Cochrane review done by De Silva Lopez et al. In 2020. And that showed that where midwives were the primary healthcare provider, particularly for low-risk pregnant women, loss of the fetus or infant death fell by 16%. So we can't really fail to ignore so much evidence. And Sheila Kitzinger, God bless her soul, I'm sure a lot of you knew Sheila. And she did so much for childbirth. She wasn't a midwife, but she was a service user, and her voice echoed all around maternity and midwifery services. And in Sheila's Kitzinger Symposium in 2015, which looked at relationships, it found that women are 24% less likely to experience preterm birth, 19% less likely to lose their baby before 24 weeks gestation, 16% less likely to lose their baby at any gestation. And women were also more satisfied with the information and advice that they received, the place where they give birth, their preparation for labour, their choice of pain relief, and their overall experience. And startup costs associated with introducing a new model of care, the results showed there were shorter hospital stays, fewer tests and interventions, so that it didn't cost any more than the current services that were being run at the time, as well as leading to improved job satisfaction for midwives. The key to implementing it and making sure it works was good leadership, allowing grassroots development of local models which address local needs, with supportive supervision and realistic planning underpinned by a positive multidisciplinary collaboration. And I think those things are really key, as we found as we move forward. The Select Committee Safe Maternity Report was published on the 6th of July, and within it was done sort of like a CQC style of report, but it was done to review safety maternity services in England following concerning reports from Morecambe Bay, Shrewsbury and Telford, and some initial findings from East Kent. And it included looking at continuity of carer within that. And there was lots of evidence submitted to the Healthcare Committee in relation to continuity of carer, but they looked at a variety of evidence, and the overwhelming evidence, it makes a difference to outcomes and safety, and therefore it is supported by the committee to continue with the rollout of continuity of carer. They felt that it still needs improvement, requires improvement because it should be rolled out for all. Felt the commitment was inadequate, the funding resource required improvement, the impact requires improvement, but they felt it was appropriate and they rated it as good for that. And then also, Sue touched on it a bit earlier, is that our maternity services currently are under extreme pressure. And there's so many things to consider, and I listed everything that maternity services need to consider at the moment at this point in time, as well as dealing with the pandemic. And as you can see, the list is absolutely massive, and our leadership teams within maternity services need all of the support, as well as the midwives, maternity support workers on the ground caring for women and their families. And we mustn't forget that as we move towards doing transformation. So I'm going to hand over to Trixie at this point. Thank you.
Thanks, everybody. And thanks, Tracy, for setting the scene and just reminding us. Oh, can you go back to the last slide? So we have been through the most horrendous time, as we all know, yet I personally am really encouraged to listen to Nat and hear about how she's been getting on with her team, and actually how her team evolved and how it's working in a way that you'd expect it to do. So I would say well done, Nat and Jasmine team down there in Medway. It's just fantastic to listen to you talk. It's really good, and actually we need you to be multiplying. Now you might say, with all these problems, where are we at in the country? But let me encourage you, for all the crisis and all the difficulties we've been through, there is almost 100,000 women in a continuity of carer team through their pregnancy as we speak. So the last survey was done in March, and we're going to repeat it shortly. But we can tell you that there are more teams in place than there was last March, 371 versus 347. And that is despite the fact that many trusts who had set up teams but not following the guidance that we'd asked them to follow, very big teams or not providing all three elements of care, different things like that, then had recanted from previous audits and said, no, okay, we realise we haven't done it right. But even so, all these new teams have come into play, 371 of them, caring for almost 100,000 women. And what's even more exciting is that these teams are being placed in the areas where women need it the most. So we've got 263 teams in areas of deprivation. That means the bottom decile, the poorest areas in England. And we've also got 246 teams in areas where there are high populations of Black, Asian and mixed ethnicity people. So the people that most need this intervention, because they're the people that suffer the most adverse outcomes, are the ones that are getting continuity. So I think we should be really, really encouraged. The graph on the other side just tells us that the majority of teen trusts are running at about 10%, but there are a few that are up to 50% and going on beyond that. Next slide, Tracy. So we do have some examples of excellent practice around the country. York was somewhere we went well, I didn't go, I was online, but Tracy went last week to where they're doing absolutely brilliantly. I think they've got 47% continuity. Likewise, Barnsley doing really, really well. And then there's some places here that I wanted to mention because they've used our modelling tools. They've tested them out. So County Durham and Darlington, I think, have now got 5 teams in place, or about to, which is about 25 to 30% of their women. They've used all the modelling tools to check it out for us to see if it's going to work. And what happened in that context was the midwives were not keen on continuity when they started, but as those teams have rolled out and word of mouth has got out that the midwives are having a fantastic time and the women are having fantastic outcomes, things like women with a high smoking rate are now dropping their smoking rates, breastfeeding rates that were really low are going up. So really fantastic long-term health implications for what those midwives are doing for those people's lives. So we see that those places are really making a difference. Milton Keynes, the informatic that you can see in the middle, the thing I wanted to mention about them was that they looked at their sick rates for their midwives and they had a 52% reduction in sickness after joining a case loading team. So joining a team, just like Jasmine, just like Nat is doing, has reduced the sickness because people have enjoyed coming to work. They've enjoyed being autonomous. They've enjoyed being empowered. And they've got a consistent and manageable workload. So we all know when we go to work on that labour ward in any trust in this country, we don't know who's going to turn up. We don't know what our workload is going to be. But because when we reorganise our work, we can feel that we're in control of what we're doing because we know that we've got a 27 woman live caseload. And therefore we know roughly what our workload is going to look like at any given time, although there is a bit of variation as Natalie described to us. Next slide, please, Tracy. So what we're looking for is how do we get from where we are now, which is a sixth of women, to moving forward? And that's, what we wanted to mention. So the Parliament, the government is behind this initiative. It's not going away, and we need to just embrace it and think of ways of doing it in the best possible way. Now, this part on the one side, the blue slide of the slide, just tells you what's been put in place by the government so far and how much money has been given, because trusts haven't been left alone. There has been a lot of implementation money made available, including that £96 million for additional midwives. And what we've also done on the other side is we've looked at how do we go from planning to achieving success. There is a certain list of things that you need to put in place, and we want to help you with this. And what I say at any meeting that I speak at is, if your trust or if you need anybody to help you with any element of this, do not be a stranger, and please just get in touch, and we would love to help you. Next slide, Tracy. Next slide.
It's not going.
Oh, okay. Just wait, everybody. We'll have a pause. Talking. So it's come up. So we've got some priorities, and actually the guidance that we've all been waiting for a very long time is just about through. It's just got to go through so many hoops and so many approvals, including Amanda Pritchard's office, before it comes out to the public. But what it is essentially wanting you to do, there's some formal things written on this slide, but what it essentially is asking trusts to do is come up with their plan and describe how they're going to get from whatever they've got. So in Natalie's example, she's got one team at her trust at the moment. She'll need probably about 19 or 20 to achieve default continuity of care. So trusts need to describe how they're going to get there and how they're going to go from the current usage of midwives in a traditional model to moving them across into a continuity model. Next slide, please, Tracy. So what we've put in place to help you is the NHSEI Toolkit, and there's spreadsheets, an example, standard operating policies, information about pay, information about training. There's even a mock board paper for people to take and fill in, so they've got something to send to the board. And essentially, what it helps you do is see how doable this is. So in the toolkit, there is an example of how you do it. And generally speaking, if you've got your traditional birth rate plus that tells you where your midwives are allocated and how many midwives you need, you just translate that across into the NHSEI toolkit, and you should be able to redeploy your midwives without requiring extra midwives. There is the odd trust that needs one or two more for whatever reason, but generally speaking, using that traditional activity and acuity ratio modelling that Birth Rate Plus does for a traditional model, you just bring that across and you ought to be able to deliver continuity of care in your trust with that. Next slide, please, Tracy. So there are, as we've said, certain things that need to be in place. And actually, what I've seen is we can all be learning from each other. So we listen to Nat and her experience. We very strongly say don't go for a shifted system. And it's exactly what Natalie experienced. You end up getting penned in. And what we want to do is give people freedom. You still know when you're going to do your birth availability. So you know when your out of hours work is going to occur. You still know when you're on holiday. So you can still plan all your time. But we can learn from the things that haven't worked well to share them with each other, to work out how we can do all of this better. And in doing that, next slide, please, Tracy. If we do it in the way that the guidance suggests, and if we use all these tools, we will avoid. I've just realised I spelled avoid wrongly. We can avoid all these. Sorry, guys. We can avoid all these unintended consequences. If we want to make sure midwives in the right place at the right time, we just use the toolkit, and it describes where all the women are, where all the midwives are. Are our ratios still safe? Yes, they are. So we're safe to proceed, and it's just really easy to manage. There's never any double running. You don't need a whole swathe of extra midwives. It avoids unsafe and inconsistent staffing if you do it properly. It prevents being tired and being burnt out because you now have unpredicted and manageable workload. And the beauty, and Nat was describing this as a testimony to this, is actually when you set your teams up well and you prepare your teams before you start, you avoid the poor team working and the lack of communication that we saw at places like Shrewsbury and Telford, because the teams are built in an appropriate fashion and therefore the teams work well. And this has been borne out by all the research that Michael West has done over the many years. So nobody's been asked to do a big bang because we know that would be bonkers. We're asking trusts to do a phased approach. We're asking trusts to do it in tandem with recruitment, so you get your right midwives in place before you start doing too much. And then, but at the same time, we do want to avoid a two-tier system. So everybody says, and I've had this said to me so many times, oh, the women get a better time, the midwives get a better time. It's not fair for the ones not in a team. So the answer to that question is, let's get everybody in a team, except for the ones that want to stay in the core, and therefore everybody's happy. So hopefully that gives you a flavour of where we are and where we want to get to. And I will give Tracy the last word with the last slide. Please, Tracy.
Thank you. I just love this picture so much. It just epitomises everything. And, you know, we want women and their families to have the best outcomes, and we want our services to be safe. So staffing women and not buildings is the way that we need to move forwards. And hopefully we can help to do that as we move forwards. We know it's not easy. It's a whole system change, and it'll take time, and it needs to be done in the right way, and it needs to be done safely as well. So we need to ensure that it's phased and developed as we move forwards. But at the end of the day, it's about women and their experiences and their families, and also about midwives' lives and about work-life balance, and about midwives and support workers as well wanting to come to work and do their job and love doing their job as well. So that's where we'd like to be. So thank you.
Fabulous. Thank you so much. That was excellent. Gosh, I feel I've been on a whistle. I have been on a whistle stop tour now with all three of you. So it's fantastic. Thank you so much. Now we have some questions coming through, and they vary quite a bit, I have to say. Now, if I'm looking away from the camera, please forgive me. I have two screens, and the questions come out in on one screen. And I'm just, if I start off with one that came in, I think for Nat, which was, where was it? It was from Siobhan Coates. Hi, Siobhan. And she said, Nat, we'll be interested to hear how you find the balance with family life. I think a lot of us are worried about how we achieve that balance and manage childcare, etc. And I think a little bit of that was alluded in the second presentation, but your view, Nat.
My view, well, I mean, it works for me. My children are a bit older, but they are still needing me. They still need me around. I'm still doing school run and things like that. I think in that respect, I have a little bit more freedom because, you know, I set my own timings of my clinic. So I can take my son to school if I, you know, when I need to. I can pick him up when I need to, because I can adjust my appointments to fit around him a little bit more. In terms of sort of like long days on call and nights on call, I think we've just made, you know, we've adapted to that. You know, I've taught him a bit more about being a little bit more self-sufficient and made him a little bit more independent. You know, knowing that I could be out of the house on a night on call, and he might have to sort of use his own alarm clock and get himself out of bed, and you know, that I'll be back to take him to school, but you know, he has to take a little bit more responsibility. And I know that's not going to work, you've got little children, but it does work for me, in terms of sort of, yeah, the family balance is much better. My children have grown up with me training to be a midwife and then me becoming a midwife, and you know, the hours that I was doing when I was a rotational midwife, the zombie mum that I used to become after my 3 nights, where I couldn't basically communicate with anybody, that's gone. That person's gone completely. She doesn't exist anymore, because I don't have back-to-back nights anymore. I have a night on call, you know, and I have a day of rest the next day. If I can have it, I'll have a day of rest. So in terms of that, yeah, you know, I think that's brought my midwifery career, you know, that has balanced. It definitely has balanced.
Fantastic. And I think what's underpinning those, you're talking, is the teamwork of your team, because you say we do this, and that's kind of so important, but also the teamwork of your family, kind of getting to grips with you being a midwife. So that's fantastic. Thank you for that. Now, Michelle says, this sounds so similar to caseload midwifery. I think so. Like Nat, I've lived and loved this experience throughout the 1990s. My concern is how will burnout for midwives be prevented as in caseload midwifery? I'm aware that in some maternity trusts are struggling to retain staff, and I think that's an issue. Certainly it's been under discussion for some time, and there is a bit of a crisis with not enough midwives. And one of the things I'm aware, it's very difficult to run this sort of system if you're short of staff. It doesn't magically work, but perhaps Tracy could answer that, maybe.
Yeah, so one of the most important things, which I think will be in some of the guidance that Trixie's talking about that's coming out, is that that we have the building blocks in place. So safe staffing is really important, and ensuring that services are up to birth rate plus establishment, or working towards it alongside rolling teams out to do it safely, is really, really important. The other thing as well that we need to consider is the ratio of midwives to women. So ratio of 1 to 36 really works and works well. I don't really think we had that evidence in the 1990s when we were doing it then. And we've built on the evidence base that we had, and we've learnt lessons from that experience as well. So I think we've got more tools in our box, and we know what works and what doesn't far better than what we did previously. So I think we're in a different space to what we were then.
And of course, in the 1990s, this wasn't fully supported financially. And as soon as I can remember myself being in a trust where when they got short of staff in the unit, they called on the teams to come and do, double up in a way, which is what you've talked a little about. I don't know if you wanted to add anything to that, Trixie. But...
Yeah, so absolutely echo everything that Tracy said, and the guidance absolutely says, you can't start rolling out teams if you're 30 midwives short or whatever you happen to be short. And I have had continuity leads bouncing up to me saying, oh, we're going to do this and we're going to do that. And I say, have you planned it out? Have you put it onto the spreadsheet? Have you used those tools to make sure you've got it exactly right? And if they haven't done it, you very quickly realise they're going to get into difficulties because they will be short. You have to check all your maths to assure yourself of safety over all the units. So I think that's the first thing to say, is setting up your teams properly is desperately important. And it's also about how you then manage that team and how you then manage the birth availability. So if you're employed for 37 and a half hours, you should be expecting to work 37 and a half hours. We all might do something over ever so occasionally, but it shouldn't be on a regular basis by any means, because you should have a system where over a 4-week period, it's going to be 150 hours. Therefore, I'm going to make sure that if I worked a bit more in one week because a woman was in labour or whatever, the following week I just take that time back, and so it balances out quite quickly. And all those things avoid that burnout. It's also, and teams can work this up themselves, because I think the more autonomy a team has, the better the team will function. But you can know 6 months in advance, when is it going to be your birth availability day? When are you going to do it? I'm going to do it every Monday night, let's say, because that's what my life needs. And if that's what you're going to do and your team is happy with that, far be it from anybody else. And then I think finally what Tracy said, we've got to remember that 1 to 36 is an appropriate number. They've used mathematical modelling to test it. It's called Monte Carlo simulation. And that then says that's the right amount. And that means someone's done a proper day's work. And we shouldn't be calling on continuity midwives any more than we should, be calling on the postnatal midwife to come back to work. Everybody, if the trust is in a crisis, everybody should be participating in coming in and managing that crisis, not just saying, oh, those continuity midwives, they happen to have a thing called on-call, which isn't an on-call in any case, but we shouldn't be calling on those people, because that's the thing that's putting people under pressure, I think, not the actual way that like Nat said, she has a far better work-life balance. But if they were calling her out every 5 minutes because inappropriately, then she wouldn't be able to say that, would she? So we need to be really mindful of, this is what we're asking people to do. And actually, we wouldn't call the postnatal midwife back, because she's done a full day's work. Why are we calling those people out to do extra in an unfair way? Although having said that, we recognise that trusts are really on their knees at the moment, and people are doing everything they can to try and mitigate that crisis.
Yeah. And I think that's coming over in some of the questions that are coming through. I know there was something on Twitter the other day about midwives saying, well, why are we doing continuity of care when we're so exhausted and stressed? And Claire has asked a question and says, what next for continuity of care? Please, can you tell me you're pausing it whilst more midwives are recruiting and allowing maternity units to restore like the rest of the NHS departments? And this is a sort of an exhausted cry, which I'm sure many midwives are feeling. And I was, as Nat was talking, I was thinking, actually, the trouble is, if you're working so hard, you have to kind of almost step back before you can see that actually this is an answer.
Yes.
As long as the right systems are set up. But I don't know if anyone wanted to respond to Claire.
So Claire, I think we hear your pain. And I have had so many conversations with people about, well, what do you do? So the system that we have, as Nat described, feeling like a zombie at the end of those shifts, that means that what we've got in place at the moment is not working, and therefore we need to give people something that's going to work better. So we have to stop doing it the way we're doing it, and we have to do something else. And as Sue just said, continuity appears to be the right answer. So nobody's pushing anybody through anything, because we recognise that each trust has to sort out its own stuff in its own way, and particularly in terms of making sure that they've recruited the right number of midwives. Otherwise, it will not work. But at the same time, as Sue said, getting into continuity teams will actually be the solution, because you will no longer be exhausted when you work in that way, because your workload will be predictable, and it will be measured and manageable, and therefore you won't be sick all the time, which is what happens at the moment. If you look at them, most of the NHS sickness rates, I think it's 3.54%. When I was a head of midwifery, and in most services I go to, it was always 6% when I was doing that outside of COVID, and it's probably considerably higher now. So we need to do something that changes it, and this is a solution for changing that bigger, wider problem that we're facing.
I have to say, one of the things that's coming over from this evening is finance, numbers. I've got jotted on my notes page, maths, and Excel spreadsheets. And I think maybe as midwives, we're going to have to get used to talking a bit of the language of numbers. Oh, never mind.
And also in terms of safety as well, Sue. This is about safety.
I've got that jotted down too.
Yeah, and making sure we've got the right numbers in place to make sure we've got a safe service first as well is really important. And ensuring that the exec team and the trust board are signed up to safe staffing.
Yeah, good. That's a good point.
Yeah,
I'd be signed up to prevent our midwives being zombie midwives. I don't like that idea. Nat, you've got me on that thinking on that one. So we've got another query. Jill missed some of Nat's session. And said, my signal kept going, so I missed some of the section, daily schedule. Can I just ask, do you cover all your team's deliveries when on call, day and night, home and hospital? It sounded as though you see your own ladies antenatally and postnatally through self-rostering. Is that so?
Yeah, so our SOP was set out to do 100% as a named midwife for antenatal care and essential visits postnatally, so first day at home and day 5. And then the team of 6 cover the intrapartum care of every woman in the caseload. So we have a day on call and a night on call. So we cover as many as we can. Obviously, there are times when 2 come at once. So we only have 1 midwife that's on call. And then, that person, first come, first served. They get the Jasmine midwife, and obviously our beautiful colleagues take up the slack in terms of on the delivery suite or the birth centre if they need to.
Fabulous, thank you. And then someone, Meg Hill, hi Meg, says, how are we ensuring that women are genuinely having continuity of care so they can build these trusted relationships rather than seeing potentially 8 different midwives during their care, which might tick the target box, but isn't what most people would like from continuity? Oh, who'd like to answer that one?
So I think what Natalie said answered the question already. So I think Natalie's already answered that. I aim to give, if you are organised, there's absolutely no reason, unless you become seriously ill or something like that, that you wouldn't give most care to your women, and you should never be palming her up between 8 people. I pick you up at booking and I arrange every single visit, and I do creative things, because working in this way, working at a 27 live caseload, gives us a lot of time to do sociable activities where you get to know the rest of the team. And then to answer from the technical perspective, we do have a process in place to ensure we will not call it continuity if it's less than 70%. So that we've got a mechanism in place to count this, and as trusts gain digital maturity, we'll be able to count this better. But actually, it's not beyond the brain of anybody to work out that you can tell them, right, I'm off next Tuesday, but come the Tuesday after, or what. That's what you do anyway. Community midwives generally get very good antenatal and postnatal continuity. What all we're doing is building on that to make it that you can get all 3 elements, because it's all the 3 elements together that seem to make the difference from the evidence base.
Fab. Fabulous. Okay, I've got a nice question from Kenya, and this is Eunice Nyasiri Atsali. Hi, Eunice. And I would be interested to learn how to initiate continuity care for our women in a medical model environment. I love the experience shared during these presentations. Thank you, Eunice. That's really lovely. Well, how could this be kind of started in a medical model? Because, of course, there are women who are going to need a more medically kind of organised care, even though it's the saying, isn't it, that all women need a midwife and some might need a doctor too.
I suppose it depends if they could work flexibly or not, whether their system would allow them to do that, because they could work it around obstetric teams. So an obstetric team working with some midwives within, and see that as a team, or working as we found this more difficult, but like we've had some diabetic teams set up and things like that, where you've had teams developed around pathology really problems, and sometimes that could work in a medical model perhaps.
Yeah, so in England, of course, we've got at least 50% probably fall into some sort of medical model, but the majority of women could be organised into mixed risk geographical teams, Eunice. That's how we do it in England. However, we do say for women that have got very high and very obvious maternal medicine risks, you absolutely can do it too. So instead of basing the team in the community like Nat sits somewhere in her community and women who live round that community place go to see her. But what you could do for those very high risk women is that you just get your team of about 7 or 8 midwives in the hospital, and each of them picks up the same. So they book 3 or 4 women a month, and then they birth 3 women a month. That the numbers would stay the same. And what we recommend in the English context is, which we didn't talk about very much today, is that we talk about having a linked obstetrician with each team anyway. And Nat actually talks about, well, she contacted her obstetrician for a woman that needed a referral in. You would do it in a far more intensive way if you were dealing with women who were extremely ill, and that obstetrician would be far more involved. But the principles are exactly the same. And so you just base it in the hospital instead of basing it out somewhere in the community.
That's great. I mean, it is a step. And Eunice, have a look at the resources. So you might find some useful things there to just try things out. I mean, but the first step is often just talking to your colleagues to see what ideas they have, because I have to say, I think midwives are incredibly creative and clever at these things and can often come up with really creative answers to talk a little bit about. Okay, now I think we've got one question for one. Oh, I've got to choose one more question. Let me see. Oh, how about Diane Ridout? Hi, Diane. And she says, have any continuity of cares engaged with local doulas to be involved? Now, that would be fantastic. I guess it depends if you've got some local doulas. I don't know, Natalie, have you got any doulas locally?
No, we haven't. No, well, we haven't sought that out as a resource. No.
Okay.
In Birmingham, we've got a wonderful charity called the Bethel Doulas. I don't know if any of them are listening today, but they pick up particularly with refugee women, and they support the refugee women as their friend almost, or their partner, because often the women have come to England on their own and they're pregnant and very, very alone, and they do an absolutely fantastic job. I mean, it's not specifically linked with continuity, but you know that you would do that if you were in an area where that kind of work was going on. You would link it with your team, just like you would also, or what we're recommending within the context of enhanced continuity is linking up with local charities, not just doulas, but you know, the food bank or different social groups, so that women really stop being isolated and things like that. And it would just depend on your specific context as to who you were going to link with and what the needs of that particular group of women was.
Okay, that's great. I have to say, we've run out of time. I'm very sad, and I know that there's been a lot of questions coming through, and we'll try and answer them online afterwards. But I mean, we have a set time, and we've come to the end of it. So I want to say a big thank you to Natalie and Trixie and Tracy for joining us, just to get us going on the continuity of care discussion. And thank you to all of you who've asked some really quite challenging questions and made some really useful comments. And we'll try and get back to you on some of them. So resources will be available on Facebook, and this presentation will also be available later on in the week for you to share with your colleagues and your friends, and maybe just open up the discussion about continuity. If you're looking at it locally, what does it mean for you as an autonomous midwife? And have you got zombie midwives where you are? We don't like that idea at all. Next week, we'll be welcoming Sophie Russell, and we'll be looking at caring for Afghan women, an Afghan clinic in the UK, and we're also marking Baby Loss Awareness Week with Michelle Lynch. So that'll be another activity for anyone who's free next Wednesday, 7 to 8. Also, don't forget to book for the next Midwifery and Maternity Festival on the 23rd of November, and the Student Experience Festival on the 10th of November, and Midwifery Education Conference also on the 10th of November. So we'll see you next week. Thank you very much for coming. Thank you again to our lovely speakers, and we'll see you next week. Stay safe and well. Bye.
The Maternity and Midwifery Forum brings you Matflix, video streaming from maternity experts. All your CPD and revalidation needs met in one place. Our expertly curated box sets are the perfect way to engage with the latest thinking, issue by issue. They make revalidation easy and are the perfect accompaniment to any project or university coursework. In addition to video from expert speakers across maternity and midwifery, there is easily accessible research and links to the latest government policy documents. Our reflective questions at the end are the perfect primer for your revalidation. In the same way the Maternity and Midwifery Forum provides certificates to show that you have attended these festivals, we can provide certificates for those who have consumed the content of a box set and submitted their written answers to the reflective questions provided by our curator, Dr. Jenny Hall. Midwives, maternity professionals and students, do not miss out. Subscribe to Matflix today. Box sets are just £17.50 each, or access to them all starts at £8.99 per month, and only £5.99 for Maternity and Midwifery Festival attendees. Students pay just £2.99 per month, and only £2.49 for Student Maternity and Midwifery Festival attendees. Check out the box sets at www.matflix.co.uk.